Good afternoon, everybody, and welcome to today's live stream session, Advancing Australia's Health Tech Opportunity. My name's Clint O'Brien, and I'm an Associate Director at CEDA. My team and I work on three content pillars CEDA thinks are critical to Australia's economic and social development. One of those being the question, how can we build vibrant Australian communities? Today's discussion on how we maximise the opportunities provided by technology and digital solutions to drive wellness is a part of that work. I'd like to acknowledge that wherever you are today, you're joining us from Aboriginal land. I pay my respects to First Nations people, and particularly the Turrbal people whose nation I'm on today. I'd also like to begin by thanking Phillips, who've been working with CEDA across 2022 and throughout the year yet to come on convening more discussions on the power of technology across the health ecosystem. We know that how well we leverage technology will determine how much we can improve patient outcomes, distribute healthcare across the community, and increase access to and equity in care. Today's session is a preview and a kick-off of this topic, for which we will raise and get into again at CEDA's annual State of the Nation conference in Canberra in September. And we're pleased to present to you today a panel of expert contributors Matt Moran, the Managing Director, Australia and New Zealand at Phillips, John Rizzo from Bupa, Professor Wendy Chapman from the University of Melbourne, Professor Jeffrey Braithwaite from Macquarie University, and our moderator for today, Penny Gregory, Principal at the Nous Group. Thank you all for joining us and adding your expertise to today's discussion. Today, for the viewers, we'll be using Pigeonhole Live for our Q&A session. You can submit your questions, vote on any that interest you that others have put forward by using the portal on the screen and the hyperlink that you'll find there. Or you can also log in via ceda.pigeonhole.at and use the hashtag HealthTech. You're also very welcome to join the conversation today on Twitter using the hashtag HealthTech and by following CEDA at CEDA_news. Now, finally, it's my pleasure to introduce to you Matt Moran, Managing Director of Phillips Australia and New Zealand, to kick us off for the day. Thanks, Matt.
Thanks, Clint, and good afternoon, everyone, and thank you for making the time to join us today. As a global health technology company, we're committed to advancing meaningful discussion that helps improve people's lives, contributes to better outcomes for our society. So thank you to CEDA and the panel of experts who are leading this important discussion today, which Phillips is proud to be supporting. The pandemic has in many respects accelerated the adoption of digital health technology, with healthcare providers, rapidly scaling up their virtual care capabilities. Digital triaging apps helped healthcare providers prioritise care while keeping their staff and patients safe, while telehealth and remote patient monitoring turned from a novelty into a necessity, enabling care providers and patients to stay connected in times of physical distancing. Faced with a scarcity of resources, healthcare leaders also saw an urgent need to improve data sharing and care collaboration. At the same time, the pandemic has exposed challenges associated with the accessibility, availability, and adequacy of care, especially for underserved communities such as those living in remote and regional areas, and aged care, and for people with disabilities and mental health challenges. The rising chronic disease prevalence and workforce shortages are just some of the long-term issues the pandemic has diverted our focus away from, but are still fueling the need for change. As we make promising progress towards post-pandemic recovery, digital transformation is top of mind for healthcare leaders. There is a unique opportunity to embed such digital, data-driven practices into everyday healthcare operations and to rethink how and where care is delivered. This week, we published the Australia edition of the 2022 Future Health Index, a research-based report Phillips commissions annually to assess the digital readiness of health systems to address global health challenges. With over 3,000 healthcare leaders surveyed across 15 countries, including 200 here in Australia, this year's report explores how healthcare leaders are leveraging data and predictive analytics in their post-pandemic recovery plans. Promisingly, we see growing prioritisation of expanding access to care, with 36% of Australian healthcare leaders saying this is currently their top priority, and a further 42% saying it will be a key priority in the next 3 years. This is fueling current investments in telehealth solutions, according to 45% of our healthcare leaders. Technology is becoming key to extending care, outreach, and education to underserved communities. And 76% of Australian leaders believe that using predictive analytics could positively impact health equity, a figure significantly higher than the global average. Excuse me. Patients in underserved communities may struggle to get the most out of digital health technology due to issues with poor internet connectivity or lower digital literacy. To prevent a growing digital divide, we believe digital transformation should take an inclusive approach that promotes access to care for all, no matter where patients live. Despite the rapid rise of virtual care and increased data sharing in the wake of COVID-19, digital transformation of healthcare has been piecemeal so far. healthcare systems need to overcome several barriers to move from pockets of digital innovation to a sustained and integrated approach to digital transformation. According to the 2022 Future Health Index, 35% of our healthcare leaders say technology infrastructure is one of the top barriers to utilising data. Most Australian healthcare leaders, 74%, say that operational silos hinder their ability to utilise data effectively, compared to the global average of 51%. Digital technologies, data analytics, and patient-centred design provide new opportunities to deliver care in more effective and cost-effective ways, like streamlining administrative processes and overcoming geographic barriers. Digital transformation has the potential to reorganise service delivery and connect disparate elements of a fragmented health system. But digital transformation of healthcare is not just about adopting new digital technology. It's about reimagining the future for the digital age. At Phillips, we envision a future of digital health as a connected and a highly accessible network of virtual and in-person care, with real-time and predictive insights supporting care collaboration across the patient journey. In tandem, AI-enabled workflow optimisation can help improve operational efficiency so the healthcare professionals get to focus on what they do best, providing patient care. And by enabling people to take better care of their health and well-being with personalised digital health solutions, we can promote a shift from sick care to true healthcare. Building a strong health system requires a collaborative approach that involves all ecosystem stakeholders, from industry, healthcare providers, academia, and governments. And that's why we're proud to support these important discussions and play our part in this transformation. So thank you once again to CEDA for organising the discussion, and I look forward to hearing what the panel have to say. Now I'd like to introduce Penny Gregory, Principal of the Nous Group, who's going to lead the panel discussion for us. Thank you.
Great. Thank you very much, Matt, for the introduction. And welcome everyone to what I'm sure is going to be a thought-provoking and challenging session here today. Let me first of all say that I join you from Ngunnawal country. I'd like to pay my respects to the elders who have looked after the land here for so long and so well. And I'm sure that in this NIDOC week, it would be great to look at some of the opportunities and the challenges that are there in relation to closing the gap, which is something I'm sure we all strive towards. So let's not forget that as we move through the discussion today. We have three great panellists here today, and in a minute I'm going to introduce each of them, and I'm going to ask them just to spend 2 sentences, maybe 3, telling us what's the perspective that they come from, not after their life history. Want to understand what's the body of expertise and experience that they bring to this discussion today. Whilst we're getting ready for that, let me encourage you to get onto that Pigeonhole link. Please put your questions there and make sure that you vote on questions so that the most popular questions come to the top. And it would be great if you add to that which of the panellists you'd like to address the question that you ask. So look forward to seeing your questions coming up there, and look forward to some challenging questions amongst them to really get this panel sparking today. So I'm going to first of all turn to Professor Geoffrey Braithwaite. Geoffrey is the founding director of the Australian Institute of Health Innovation at Macquarie University. Geoffrey, can you just give us those couple of sentences? What's the perspective you bring to this topic today?
Thank you, Penny, and I too acknowledge the lands on which various people are, and sorry about that, and acknowledge elders past and present who may be present or not. So. My perspective is I'm a researcher. I've been a researcher for about 25 years, and I run a large research institute devoted to doing studies to improve health systems here and internationally. So we essentially work in not just Australia, but 152 countries, looking at low and middle income and high income settings and trying to figure out how can we do research to illuminate progress in improving care for patients. So my perspective is to dip into studies we've done and research others have done to try and understand how we might create economic development, improve healthcare from that perspective.
Great. Thanks very much for that, Geoffrey. I'm going to now turn to Professor Wendy Chapman to introduce herself. Wendy is the Director of the Centre for Digital Transformation of Health at Melbourne University. Wendy, over to you. What's your perspective?
Thank you. I also come to this with a research perspective. focused on informatics, which is really the science of information, and how do we leverage information to support decision-making and improve processes. My background is actually linguistics, and I found informatics because of natural language processing, which is extracting information from clinical notes that are written about your care, extracting that information, putting it into databases so it can be used for decision support, for research, for surveillance. And so I come from that background and have moved, pivoted multiple times to try to think, how can we really have impact on the healthcare system? That AI and algorithms that we develop are all part of a big picture, of a huge ecosystem of how to do that, and using the learning health system framework in our work here.
Great, thank you for that, Wendy. And then to our last panelist, John Rizzo. John is the Director of Accelerated Growth with Bupa. So John, what's your perspective?
Good afternoon, everyone. Thank you, Penny. So I look after the customer portfolio of Bupa across our 9 businesses and 3 geographies in Asia Pacific. Spent about 20 years working with and talking to customers in the services context, and the last 11 of those in the health sector across all elements from funding, provision and care. So the perspective I bring is that customer view, a value proposition view, and an adoption of technology view. Thank you, Penny.
Great. So thanks very much for that to the 3 panelists. What we want to look at today is obviously the opportunities, both from a social side and an economic side. And let's remember that they're not necessarily coincidental. They don't always work together. So we want to try to establish what are those opportunities on the social side of things, well-being, better connected care. What are they? Also, what are the economic opportunities? What difference might all of this make in terms of productivity and the whole economic side of the health system? But we don't only want to look at opportunities, we also want to look at what are the risks and what are the barriers. Why hasn't this happened in Australia to date in a more fulsome way? So first of all, the question I'd like to ask to Wendy, what do you think, Wendy, are the real opportunities in terms of better healthcare per se coming out of the kind of technology you're looking at? Where do you think is the biggest opportunity?
Thanks. I would say that there's too much information out there right now for the human mind to process. And the real opportunity is getting that right information to the right person in the right time and the right format, and so that they can make the best decisions. And so concretely, that's participatory health, where patients are collecting information about themselves, and they are bringing that to the clinical visit to work with their GP or their specialist and feed that information in and have better discussions. It's clinical decision support to bring the best knowledge and guidelines, evidence-based guidelines, to the point of care and help clinicians, have access to that in the context of the patient and the symptoms and findings that the patient has. It's on the population level of not just treating one patient at a time as they come in with the same amount of effort and care, but really focusing on patients that are at higher risk and being able to give them, more intensive attention and support, which may be clinical and it may be social, it may be economic. And so it's really leveraging the data that we have now in a way that supports that collaborative care and better decisions.
Okay, thanks for that, Wendy. And I think that's a really interesting angle to take on this, that trying to leverage the data that we have today. I don't know if anyone has seen, but I just saw a press release this morning from the AHHA, the Australian Healthcare and Hospitals Association, with the headline that Australians are missing out on technologies that enable data-driven improvements in health. So a very interesting coincidence of issues coming up here. I think that coincides with the AIHW, my former organisation's launch of Australia's Health 2022. But certainly one of the headlines coming out of that is that we really are not making the best use of the technologies that exist in terms of interoperability, in terms of using the data. So, Jeffrey, I'd like to move to you with that same issue. What do you think is the biggest opportunity there, or what are the missed opportunities? Sorry, you're on mute, Jeffrey. The call of the pandemic.
First time I've ever done this, Penny, so yeah, just switch the mute on. Yeah, thanks very much for that. So it's an intriguing question, isn't it? And this whole hour is actually highly challenging for some of the reasons Wendy gave. So much data. Let me just add to that. I did a quick search on PubMed about 15 minutes ago, just before I came on, and there's 10,093 articles. If I tap in eHealth into PubMed, the big medical and health database, and many of those are studies and papers that people have written on eHealth. That tells you a couple of things. Firstly, for the audience who are interested in exploiting or creating economic leverage or social leverage from eHealth or digital stuff, there's plenty of opportunities to look at the literature and see studies that people have done that might help them in their quest to make their contribution to improving the way we use data and the way we exploit digital endeavors. That's one point. Second point is, I think there's a huge opportunity just hidden in plain sight, and that is what consumers think of the health system. So we did a study, the Australian Sentiment Study, in October last year. Admittedly, it was in the middle of a pandemic, so there's some noise in the survey responses from the fact that people were, some of them locked down, some of them just coming out of Delta, some of them coming into Omicron variant, etc. But about 14% of the population said they didn't have enough money to pay for the healthcare that they needed. 24% of people didn't fill a prescription because of some sort of cost pressures. 30% of people with chronic conditions said they didn't think they could afford the care if they became seriously ill. Now, we like to differentiate ourselves from the US health system, but I think we might be marching towards, not away from, some of the blemishes and problems in the American health system. Just a couple more data points on that survey. 39% of people had used telehealth in 2021 compared to 6% pre-pandemically. So there is, although Wendy's right, there's not a take-up sufficient of all things digital, and you made that point too, Penny. I think there's more of a take-up, and when we have something like a pandemic, we can use that as an opportunity rather than a threat.
Thanks for that, Jeffrey. And building on that whole idea of what customers want, what they're seeking, I'm going to go to you, John, because I have a question here that's got 3 votes. So a bit of a popular question here for you, John, which is really about that. What are customers looking for? Are they seeking more digitisation of health services in your experience in Bupa?
Great question. It's a tale of a difference between desire versus behaviour. So is there a desire from people, from customers, and I would expand certainly beyond just Bupa, say health insurance customers. Is there a desire for more digital health? Absolutely. And it's extremely strong when you ask somebody what they are looking for. The idea of extrapolating the convenience, the connection, the continuity of contemporary digital services that people are experiencing in other aspects of life and applying that to health is extremely appealing in concept. Behaviour doesn't follow. And we saw obviously the huge spike during the lockdowns from COVID. That has eased off, not completely. We're still, the new norm is well and truly above what it was before. But there's absolutely a significant gap between the latent desire to engage in digital health and actual behaviour. And some of the barriers that people talk about that lead to that is firstly a belief that I'm going to need an in-person visit anyway. So what we might perceive as being convenient is actually, from a perceived value perspective for a customer, a net inconvenience, in that I'll probably need to do this digital consultation and then I'll probably need to do something else that follows. And that's not great from a customer or a provider proposition, because the provider's then facing a funding challenge. Do I charge twice if that person does need to come in? You look at general practice consultations during, what was the period, March to December 2020. So, that core lockdown in the first part of COVID, of all general practice telehealth services, 97% were on the phone. 97% were phone, not like, as we think, connected data, a video consultation like this. It was not particularly sophisticated when it came to digital health. That's not what people are looking for, and we simply haven't yet addressed the barriers to adoption. That's only one that I mentioned before, about that concern of needing to go into a physical environment because of what we can't do in the digital sense. And that's something which needs to be addressed if we're going to see the gap between desire and behaviour closed.
Great, thanks for that, John. And so you've touched on what some of the barriers are coming up from the community. We have a question, though, that goes more specifically to what is it that needs to be done in order to overcome those barriers. So does one of our panel members want to talk a little further about what are some of the things that actually need to be done to overcome some of those barriers? You've talked about, well, I'm going to have to go see the doctor anyway, so what's the point? Have one of the other panel members like to comment on what can we actually do to overcome some of those barriers from that community point of view? So over to you, Jeffrey.
So, we often talk about digital literacy, digital e-health literacy, and it's almost the way we speak about that. It's, well, why aren't all those people more literate? But I wonder if the providers of the information have a big role to play, and a much better role to play. When you go on to see the content in apps and on websites that purport to give you information about the health system or about your condition, it's like the Wild West. And some of it, I'm in this field and I find it difficult to read what some people are actually saying. The number of apps that we have, many of which have never been evaluated, and Wendy can talk about that for sure. We sort of tend to think this is a problem of the community not being digitally e-health literate. But I think providers of information have a big role to play. A few years ago, Penny, you'll remember, there was a big move to say we can't keep having all these massive 100-page contracts and we have to have plain English contracts. Never really went very far, unfortunately, and it should have. It's the same now, I think, with all the information that we've got stored and is purported to be accessible to people. And it's like reading, an advanced foreign language. And we really have to de-acronize and we have to make things simpler for people to understand and give them information that they need. This is John's wheelhouse. Give them information that they need at the time they need it, that's fit for purpose for them.
Okay, thanks for that, Jeffrey. It's the whole demystifying. And I was interested, to hear you talk about the need perhaps to simplify it all. And there are many apps out there. There are many different approaches and ways to go forward. And how do I, as a consumer, know which way to go? I'm keen to ask Wendy as a follow-up to that. Is there some need for some kind of regulation? Is there a government intervention requirement here? That's a bit of a big challenge to the market out there for digital technologies. But what's going on with this plethora of technologies? How can we make sense of it?
Well, I think there certainly is a role for regulation, and there's a role for legislation to really encourage the types of infrastructures and laws that will help, support us in supporting patients better and citizens better. And like Jeffrey said, right now, we as Australians or permanent residents, as I am, we have almost no access to our health data. And technology can really help with that. And so patient portals are starting to be opened up. But I've had a patient portal in the US for 20 years, and I have all kinds of data on that I even use today when I see my GP here. So we need to be able to give access, that data access, and that requires some government legislation in that. But also, we need to be helping them with knowledge, and technology gives us the opportunity for that as well. Because just dumping a bunch of data on a patient, or a patient dumping a bunch of data at a clinician of here's what my Fitbit said, is not going to help us. So data is just the beginning of it. And so I think there's a role for government and health services and consumers as well. I think that right now, I like that term, the wild, wild west. That's what it's like. There's over 300,000 health apps in the app stores. And very few, you can almost count them on your fingers and toes, are being used at all and have been evaluated. And so we're at this place where the technology is not the problem. Technology can really help deliver what we want to help, that we've been describing. But it's that gap between the technology and the integration of it into the healthcare system. And so an app that just helps a patient is often not adequate, because they need information from their healthcare provider, and they need to talk with their healthcare provider about those things. And so it's this coming together of the health system and the person, and we don't have processes for that.
Okay, it's a bit like consumer beware, isn't it? There's a lot out there, and how are you going to work out and integrate that into your own healthcare? So I'd like to change topic just a little, because we have a number of participants who are keen to hear thoughts from the panel on how they see that technology can improve patient outcomes across regional, rural and remote communities. So clearly it's a big issue in Australia with our vast land. How can patient outcomes be improved through technology? So we talked a little bit about telehealth, that kind of avoiding the face-to-face. But John, what's your experience of regional, rural and remote? Is it around the telehealth? Are there other things? What about at the back end?
I might look at it maybe too simplistically, but simply access to care is obviously more challenged in a regional and remote setting, and that creates an incentive for people to engage in digital health to deal with some of the risks and the friction that we're highlighting here. I think anything you look that's been a success in digital health, particularly at scale, it has found a position with people, a value proposition with people that is seen to be better than the physical alternative. If you look at eucalyptus, as now worth $500 million, where have they differentiated? Sexual well-being, erectile dysfunction, hair loss, things where people are a little bit embarrassed to be face-to-face, and have built digital health businesses around those things. Now, rural and remote, simply finding the right clinician, the travel to the clinician presents a barrier. So digital health is absolutely appealing from a relative value perspective. I think we've done well as a country where we've always had higher funding for provision of care in a digital setting into rural and remote. What we haven't done as well on is some of the stuff we've talked around connecting data, continuity of care between digital and the physical setting. And we do have technology barriers and problems still, despite, as we all know, promises of NBN and whatnot. That is still cited as a barrier for many people in regional and remote when it comes to digital health.
Yeah, and look, following on from that, John, there's a fear, and some participants have noted it, that health technology introduction could in fact increase the health inequities out there by the digital divide. So are you aware of things that can be done to try and ensure that there isn't, that the more limited access to health in rural areas that we know already exists might be overcome?
Well, I think the opportunity is there, Penny. I think that's the thing to focus on. That we've absolutely got the opportunity to bridge that divide rather than exacerbate that divide. I see no reason why we should that this would be more successful in a metro. The better served populations in metro areas. I think that the challenge that we have is common between metro and regional when it comes to that is the barriers to adoption of digital. And I think what we can do is we can focus on rolling out that. When we solve those barriers, we roll out that capability into regional and rural areas first. The reason I think that makes sense is because, again, those are communities that have a more inherent incentive to engage in digital health because of the friction faced in accessing healthcare services today.
Okay. Right, thanks for that, John. I wonder whether we might move on to the vexed issue currently of health workforce. Are there ways in which health technology can help address the workforce challenges? So we've got workforces right across Australia, everywhere at the moment, but we certainly do in the health system, whether it's from aged care through to general practice. We've all heard about robots that could be used to dispense medication in aged care facilities, and perhaps are used internationally in some places to do that. Is that a way of addressing workforce challenges, or are there other ways that are feasible and potentially could be brought in to address workforce challenges in health and aged care? We have a couple of participants keen in understanding this. Jeffrey, is that an area that you've looked at?
Thanks, Penny. Healthcare's been the same but different for decades. Healthcare's intriguing. It's high tech and high touch simultaneously. It requires real people delivering care to patients in all sorts of different ways, treating them, giving them advice, caring for them, intervening, but with technology. The technology has gotten more sophisticated and made care more complex, but the necessity for people being sometimes requiring high touch hasn't gone away. So yes, people talk about robotics, which you raised, Penny. It's a fantastic question, intriguing. But also, let me just broaden that. All sorts of technology tends to make the delivery of care more complex. It tends to give new problems, that it solves some problems and throws up new problems. I'm thinking about electronic medical records, which can create new errors. We used to think, that's going to fix the problem. Wendy's a linguist. She might have a comment on this. That's going to fix the problem of doctors' handwriting. But the introduction of electronic medical records threw up new problems that we didn't really anticipate. So I don't think we can get away from the fact that healthcare has to be high tech and high touch. It's going to become more complex over time. The capacity to treat a wider range of patients with more and more conditions, aging populations, for example, and yet we still require high touch when it matters. And that's a problem for rural and remote, but it's a problem for cities as well. Just scale back that a bit as well, Penny. It's a fantastic question from our audience, by the way, just scale back from that. There's about 1,060 hospitals, if you just take hospitals in Australia. Most of them are very small places in a small country town somewhere, a small rural or remote setting. And only a few of them are big teaching hospitals where all the ologists are and all the high tech is and all the super specialization is. We tend to concentrate on those, though, those latter ones, and not so much on the other ones. So if we're going to provide equitable care, I don't think we can even remotely start to think that we need a teaching hospital in every suburb, in every country town. We're going to need people to travel, but it will be very important to provide a good standard of care in all those small places in country towns. So what we have to get better at is recognizing there are cases that stay there in the country town or the rural or remote setting and get dealt with adequately, equitably, appropriate with good access. And there are times when you need to travel to go to one of the big Taj Mahals to get that super specialized treatment that you need. So what we need to be better at is using technology to sort out, triage patients into the right place. And we also have to be better at recognizing that we will be treating many, many more conditions over time as the population ages and as we get better at treating chronic and complex conditions. And care isn't going to get any easier. It will remain high-tech, high-touch, and complex. So that's the kind of dilemma. But I think we've got to get better at that.
Great, thanks, Jeffrey. And it is reassuring to know that people are still going to matter. Hands-on care is still going to matter into the future. I think that's reassuring to all of us. But I wonder about, in terms of the workforce, productivity is the other issue, isn't it? And whether or not some of the ways that technology can actually create better productivity by not having to redo things, by making things so much simpler. I wonder, Wendy, have you got any perspectives on that whole productivity issue in terms of the workforce and technology?
Yeah, a couple of thoughts. Just the issue that Jeffrey raised as well about being able to focus on the patients that need more intensive attention and care, and using technology to point us to those patients and triage to them. Also, being able to make specialists available to non-specialists, and that might be through telehealth consults, with specialists, but it also might be, there are best practices and there are, protocols for doing screening and things, within certain fields, like let's say suicide screening. We have one clinician here who's trying to develop a decision support aid for non-psychologists and psychiatrists to do screening for suicide. And there are best practices in how to do that, but the average GP doesn't have that at her fingertips. And so being able to make that type of knowledge available to non-specialists to help guide them and, send the patients to where they need to go and give them the access to the resources that are potentially available for them. And then finally, I would say, technology can often take away some of the work that's just not needed by someone at such a high level. For instance, with artificial intelligence and image recognition, if you're able to recognize chest x-rays, let's say in Africa, that are normal, now that very rare radiologists can spend time on the more complex cases and not have to spend a lot of time doing things that could be filtered to support their productivity.
So there's some real opportunities in there. So thanks for that, Wendy. I'm going to move on to another question, which relates to the rise of social media and fake news. So how do you see that whole social media context playing into healthcare industry reforms? The question is, how are we going to continue to manage data privacy and medical security moving forward in this whole era of social media? We don't mind what we put on Facebook, but don't ever let any data about my health get out without me putting it out there. So John, have you got a perspective on that one from the work you do on the consumer perspective?
Yes, that's a fascinating question. Thank you to whoever asked that. Something to level set on, when it comes to health and wellbeing, I'm going to abuse the floor of averages for a second, and say that your average adult engages with the getting well part of the healthcare system for about an hour a year, about 60 minutes. There's 525,000 other minutes where health is just looking good and feeling good each day. Yeah. Sometimes we forget that because we focus so much, understandably, on getting people well when they need to be. But that time, that looking good and feeling good, a lot of that is spent on social media. And when I talk to customers these days and say, hey, how do you learn, understand what's out there for you when you're thinking about just looking good and feeling good, getting, living your life the best you can. They go, oh yeah, TikTok, Instagram. In a post-truth world, it might scare the heck out of us, right? But this is how people are choosing to learn when it comes to health and well-being. That should encourage and scare us. Yeah. In a post-truth world, it scares us, but there is an opportunity there. There's an opportunity to have a very different and ongoing conversation with people that is a series of little nudges every day that create a different understanding of one's own health and well-being, of looking good, feeling good, that lead to different outcomes. So I'm an optimist. I choose to look at the opportunity in that space. But yeah, in a post-truth world and looking at how people choose to engage today, there's certainly good reasons to be concerned.
Mm-hmm. Okay, Jeffrey's itching to talk about that one as well. Over to you, Jeffrey.
So this is amazing. Let's just take three worlds. Let's take the world of the policymaker, the world of the researcher, and the world of social media. So, for me as a researcher and Wendy, to get access to quite static data sets, we have to go through so many hoops. It's not funny. You've got to get ethics approval and you've got to persuade an ethics panel that you can actually access the data. And then when we gather it, we've got to make sure it's de-identified and nobody else can ever access it. And it gets published in an obscure paper somewhere in an obscure journal and maybe gets cited by some other colleagues like ourselves. The policymaker is developing policy and trying to influence the system through funding and policy, essentially, and is also on a very slow lead time, essentially, because of the nature of the policy process and politics and government departments. And Penny, you know this, you've lived and worked in Canberra. Then there's the world of social media, Google, Amazon, Facebook, TikTok. They are influencing health behaviours and health-seeking behaviours every minute of every day in real time with no ethics, no need to write any policies, no need to do anything, to ask anybody, any government, any permission. They're just doing it. So what we need to do is somehow get those three worlds working together and not dealing with a currency of misinformation, whether it's researchers not interpreting information very well and publishing errors in their papers, or policymakers not writing very good policy or putting incentives in the wrong place, or social media just going and doing whatever it does to influence people in the wrong direction. That is like Himalayan. That's a Himalayan challenge to climb. But that's what we've got to do. Otherwise, we will be victim, as you rightly say, and as the audience rightly says, about misinformation or keep trying to hit the wrong target. And that's going to be a big problem for us. We haven't reconciled those three worlds.
Indeed. Thanks for that, Jeffrey. I wanted to turn to another topic at this point. So it's about the investments that we made in Australia into technology. And the question that's come from some participants is a specific one: how much is the shortfall comparative to other OECD nations in terms of what we invest? I'm not sure that any members of the panel can answer that one off the top of their heads, but please let us know if you can. But it's an important one to bear in mind. But essentially the question is, are we making enough investments into technology across the health system? Wendy, what's your perception on that question, and particularly given you've had 20 years, I think, in the US before you came to Australia?
Yeah, well, of course, I'm going to say no. We are not making enough investments into this space. But, if you think about the money that goes into drug development and the processes that are in place that are very rigorous, and evidence generation that's required to put a drug, into market, it's just huge. And in the digital health space, there's very little investment made. And you can develop any kind of digital tool and put it on the market and try to get people to use it regardless of any evidence. And so I think we need to have more investment in the infrastructure to support the evidence generation of these interventions. And not just the evidence generation, but the development of them, because there's so many unanswered questions. I mean, if you're going to give somebody a pill, it's pretty clear how they're going to use that pill and how they're going to take it. But if you're going to create a digital intervention, there's 10 different ways you could implement that. You could text patients information. You could create a dashboard that they log on to. You could show, something to a clinician before the visit, during there's like so many ways you could implement the same intervention. And we don't know the best ways. But there's lots of processes that are used by Google and other places to really test out these different ways with real users and have them help co-design and validate them before we actually put them into practice. And I see a big gap there.
Okay, that's a really interesting challenge to us all. Thank you for that, Wendy. I'm conscious that we're getting towards the end of our time, and there are some other questions here in relation to interoperability of the health system. I once worked for a chief minister who said, and it's probably not very appropriate in the current environment, but if you got on the plane in one place and you had to change planes somewhere else and you had to completely re-identify yourself and go through the whole rigmarole again, which you might have to do currently, but we won't go there. How would you feel about the whole airline system? And essentially that's something that we've consistently had to do in health, to try to get systems interoperability, to try to get the transitions between care working better. So one of the questions we have is continuity of care across healthcare providers requires the integration of data at the semantic level. Is there any intent to support the interoperability infrastructure? And that again goes to this press release from the AHHA that I mentioned before, which is basically saying it's not because there's a lack of the technology out there, it's not because clinicians are not trying to drive this, it's a lack of investment in the interoperability. Any of you want to comment on that one? We might start first, perhaps, with you, Jeffrey, in terms of interoperability. You're on mute. Sorry.
Thanks, Penny. I was just unmuting. Yeah, it's a great question. I mean, there's so many different ways you can tackle this, but let me just put it this way: we've had a go at that, haven't we? My health record. So I'm not sure if that's the final destination for where we might be in terms of solving this problem. But the only constant in someone's healthcare is the patient themselves and their journey. And so we have to wrap this around the patient and their interaction across the lifespan with their data, with what happens to them across time. If we do that, we might get to a situation where you don't have to account for yourself every single time you go into the health system. And you might be actually more patient focused. I don't think we've used that term yet. You might be more patient focused than currently the system is. The system is still set up for all the 20 years that we've talked about patient focused care. It's still set up for providers, hospitals, community health centres, aged care facilities, and individual providers providing care. We still haven't reoriented the system. And I think so many things fall away when you do that, if you can do that that you start to have a much better system, and interoperability then follows the patient and the data gets gathered around the patient. But there's so many privacy, technical and economic issues to solve on that pathway. My health record was the beginning of that, but it's not the end point.
Thanks for that, Jeffrey. And John, I wonder whether you have a perspective on that one in terms of interoperability.
Yeah, it's very consistent with Jeffrey's perspective, and that is, I think about where's the incentive? Who has the incentive here? It's actually no one element of the provider side of the equation actually has the incentive to drive interoperability. The patient does if you can prove how sharing your data can increase value for you, reduce friction, lead to a better outcome. I'm a strong believer. My health record, love the intent, hate the execution. The greatest tragedy for us as a country would be to ignore, to not have another go at executing around that, and throw the baby out with the bathwater, right? Simply calling it something like my well-being ID, and then making that a QR code that's frictionally, accessible, no matter what provider you go to, and then suddenly people drive the adoption. We've got to acknowledge that the healthcare system will never be set up with digitally enabled technology stacks like contemporary businesses are. We're talking big mainframes, hard to impact, hard to connect. It's not an API connected system where you can easily move data between in a secure way. So who can push through that? Jeffrey, couldn't agree more. The customer can do that with their phone. An individual can do that no matter who they're engaging with. And that's where I think the change will be driven from, with some help on regulation and whatnot. But yeah.
Yeah, thanks for that, John. And an interesting follow-up to that one is actually a question, perhaps I should put it to you, John, but have we got too many vested interests here in Australia right now? And is that really a barrier towards uptake of technology across the health system? Maybe I shouldn't ask you that one, John, but please, yes. We'll go to you, then on to Wendy.
Well, go ahead, John, if you want to say a few words.
Oh, look, I think just on that, I don't actually think it's, I think the vested interests reflect the way we structure funding, the way we pay for health, right? So vested interests can change very quickly if we align funding models. What we're trying to do is we're trying to take the offline paradigm of face-to-face care and appointment-based, and we're trying to just apply that in a digital world. And we go, why isn't that working? We need a funding model which follows, asynchronous conversations over time, moments of interaction spread out rather than a 30-minute appointment or a 15-minute appointment or an hour appointment. Like, that's how we can change the vested interest. I don't believe, again, I'm an optimist. I don't believe those things are immovable, but we tend to look at them as this thing that can't be changed. So.
Have you talked to the AMA recently then, John?
Oh, yeah.
Okay, Wendy, your perspective on that one.
Yes, I completely agree. And I think that there's no solution without the patient being the solution and the person. And I really love the work of George Crooks in Scotland. And they're looking at how do you really empower the patient to be the holder of all their knowledge, not just the healthcare data, but also, the data from the government and, everything, and that they're able to provide permission for different people to see that information so that information that is all about them is held within their control. And I just think this fragmentation that we have, we're never going to accomplish what we want to with it in place. And the patient's the only way to solve it.
Great. Thanks for that, Wendy. And I think we have time for one last question. And Jeffrey, it's one that a couple of people are keen for you to answer, which is the obvious impacts to mental health and feelings of isolation, reduced in-person care with the rise of digital healthcare. How are we going to manage that? You referred before to the need still for in-person contact. With the rise of digital healthcare, how are we going to manage this potential impact on mental health and isolation?
Fantastic question. Thanks for the question. So just back up a bit on that other. I agree entirely with my colleagues on the panel about the answer to the last question. Over the years of looking at the health system and investigating it, though, I've realised that all interests are vested, and everybody's invested in their own position. But I also know that none of us individually is as smart as all of us, and so the answer has to be coming together perhaps in a big summit to deal with some of these issues. Now, I hesitate to say that because it's got a bad history in politics to bring back a summit. But why I'm saying that, Penny, is, and I think you'd agree with this, we haven't done a very good job of putting the digital stuff that we're talking about. The elephant in the room for me is we haven't got a really good game plan for 2030 about what the health system might look like if we get it right. I would put our discussion, even the work of Nous and Phillips and CEDA, or all of us, into a what would we like the health system to look like? Patient-enabled, more integrated, offering better value for money, more patient-based, with universal coverage, so we've got more equity. You know, it's not difficult to specify what we'd like for a health system by, say, 2030, and then say, now digitally, let's ask the question, how do we do connectivity? How do we create a patient-orientated system? So I would do it that way. I think sometimes we've got this back to front. Onto your question, your specific question, this is a big issue. Again, that survey that we did, the Australian Sentiment Survey, Penny, which we administered last October, generalisable to the whole population, 5,100 respondents. And 23% of people believed that aged care was no good. Well, we know that. You just have to pick up the paper. That's for those who aren't millennials and never pick up a paper, of course. And 24% of us in Australia reported experiencing serious psychological distress. 1 in 4 Australians. The burden coming from not just the pandemic, but modern life is absolutely crushing for many people. We just have to make more investments. We have to do both face-to-face treatment, but also you can do a lot remote, digitally, through teleconsultations, and we have to do more about mental health. It's a crushing burden on the Australian population.
Great. Look, thank you for that tiny reminder there, Jeffrey. And thank you also for the suggestion of not just a jobs summit, but a digital health summit, how we bring the health system together. I think there have been a lot of interesting ideas come out of today, interesting, challenging ideas. And I particularly want to thank all 3 of the participants for the great contributions today. It has been really interesting, and I think there are quite a few things that we could take forward out of this and change the world, but also some rock solid reminders of what's going to be needed over the next period of time. I want to thank all the participants who have joined us today, and thank you for the really interesting questions that have come through. Can I remind you to please take a moment to rate the experience that you had of this event in Pigeonhole, please, before you leave today, and also keen to ask you to look out for the post-event email, which will include a link to today's live stream recording. Important for you to stay in touch with upcoming discussions via CEDA, ceda.com.au, and you can register for CEDA's next live streams. I think the next one, Clint, coming up is on Tuesday, the 26th of July, the Economic Update Inflation, and then the annual conference, State of the Nation, in Parliament House on September the 8th. So thank you very much, everybody, for participating, whether you participated via questions or via the panellists. I think we have approximately a minute and a half left. And I just want to ask each of the panellists to finish off. For you, what's the one word that is the biggest opportunity, presents the biggest opportunity in healthcare from technology? What do you think is what's the best outcome that can possibly come from a greater investment in technology? I'll go to you first, John. Put you on the spot.
Customers patients become the catalyst. That's where we need to focus.
Patients is the catalyst. Interesting, isn't it? We talk about technology and we come back to patients being the catalyst. Thank you for that. Jeffrey, what would be yours?
Yeah, I'd empower the patient.
Two lots of empowering the patient. Okay, Wendy, where are you going to go?
I'm going to say value.
Okay, value-based healthcare, ensuring we get the value out of the technology, which is a theme that you've been talking about today. Fantastic. Right, I think we're at the end of our time. Should I hand back to you, Clint, to say farewell to everyone?
Sure, absolutely. Thanks, Penny. Good afternoon again. Wasn't exactly the plan, but very happy to wish you all well for the rest of your afternoon. It is a good opportunity for me to thank Penny and all of our participants. Jeffrey, thanks very much for the suggestion. I absolutely love the idea of a big all-in together, and it's something that I'll get back in touch with you all on. I can see a lot of heads knocking around the place, so we'll definitely do that. Thank you all for joining us this afternoon. I trust it's been an informative session, and thanks to all our participants. Again, special call out to the team at Phillips for their ongoing support of CEDA's work in this area. I wish you all a good afternoon and a good evening. Take care of yourselves. Bye-bye.
Thank you so much.
Thank you.